Now to introduce our speaker, Dr. Ari D. Barron, who is the chief of the Division of Hematology Oncology at California Pacific Medical Center. He is the associate clinical professor of medicine at UCSF. His practice has been at CPMC for over 20 years. He also serves on the board of governors for Southwest Oncology Group, one of the largest national Cancer Institute cooperative cancer research groups. Dr. Barron's main focus is in clinical research, where he has helped develop new medications for cancer patients across a broad array of diseases. He specializes in gastrointestinal cancers of the colon, liver, and pancreas, and urologic malignancies of the prostate and bladder.
Thank you for the kind introduction, and thank you everybody for being here. The other thing that Twin didn't mention is that I've been on the board of directors for Community Health Resource and actually served as chair of the board for a while. And Community Health Resource is one of the jewels in the crown of Sutter CPMC. It's the really the best and only place where you can get health education, everything from nutritional counseling to support group and psychiatric referrals, your DMV placards, and smoking cessation and everything in between. So we do a lot, and I should say that Twin and her colleagues do a lot to really provide the all of the kind of some of the most critical aspects of clinical care for our patients are provided by Community Health Resource. And the fact that it's a nonprofit allows it to sort of sustain itself. But I'm very grateful for the work that she and her colleagues do. And I'm happy to help provide some of the health education that we promote. So anyway, with that, tonight we're talking about colon cancer. And there's so much to talk about in colon cancer. I'll go through these, and then toward the end, we'll open it up to questions, and I'll do my best to answer them for people, and we may double back and spend more time on some of these topics. But a bit about colon cancer, a little bit about epidemiology and statistics. You know, how common is it? Who gets it? Some risk factors, screening, why do we screen, who do we screen, and how do we screen? A little bit about genetic syndromes. It turns out a lot of cancer, we don't actually understand why certain people get it, but certain people have genetic predispositions, and those people can be clearly identified, and a good strategy for screening can be put in place. Then we'll get into the nitty-gritty with a little bit more about the cancer itself. What does staging mean? How do we stage it? What is an appropriate initial workup for patients who are just diagnosed? And then if we have time and if people have the appetite for it, we'll talk a little bit about current treatment paradigms. So what is cancer in general? Well, there is many different kinds of cancer, practically as stars in the sky, but we'll say at least 100 different diseases. But one thing that is common are the following two characteristics. Cells that make up cancer experience growth, and that growth is uncontrolled and without meaning. So normally growth is controlled and is purposeful. So as you evolve from a child to an adult and your organs and body mass grow, that growth is tightly controlled and meaningful. So your heart and liver and lungs grow to fill the spaces that they should fill and serve your body's needs. Cancer growth is unlike that. It's uncontrolled. It doesn't fulfill any normal physiologic need. And it is actually, of course, detrimental to you. So uncontrolled and growth is the first hallmark. And the second hallmark is the ability to move. Under normal circumstances, cells stay put. So your liver cells stay in your liver, your lung cells stay in the lungs, but cancer cells don't stay put, they move around. So it's those two things, uncontrolled growth and the ability to travel within the body, which are the unique hallmarks of what makes cancer cancer. So what about cancer of the colon? Well, it's the third most common type of cancer and actually the second most frequent cause of cancer-related death in the United States. It's a disease in which normal cells that line the colon and the last 12 centimeters of the colon is called the rectum. Anyway, it's a disease in which cells that line the colon and the rectum begin to change, grow without control, no longer die as they're supposed to, they sort of live on. And again, they have the ability to move from the colon to other parts of the body. Usually begins as a non-cancerous polyp that over time becomes a cancerous tumor. Here's a cartoon of the intestines. Hopefully you can see my cursor. These are the small intestines where food nutrients are absorbed from the food. And then the small intestine ends in your right lower quadrant down here near your appendix. And that's the beginning of the large intestine, otherwise known as the colon. The colon then goes up. That's the ascending colon because it's going up. Then it cuts across, called the transverse colon because it cuts across, and then it goes down, and that's called the descending colon. The last portion of the colon sort of swings around in an S shape, so it's called the sigmoid for the S, Latin sigmoid, and it sweeps around, and then that last little portion of the colon is called the rectum before it opens up at the anus where stool is evacuated. So the colon is ascending, transverse, descending, sigmoid, and down to the rectum. So that's the normal location and name of the large bowel, the colon. The primary function of the colon is to turn liquid stool into formed bowel movements, i.e. to absorb water. Really, the nutrients are absorbed in the small intestine further upstream. What are risk factors for colon cancer? Well, polyps, and these are non-cancerous or sometimes precancerous growths that people get as they age. I'm not sure if I'd really call it normal, but anyway, it is associated with aging. And indeed, advancing age is a risk factor for virtually any malignancy. People who have chronic inflammation related to inflammatory bowel disease like Crohn's disease or ulcerative colitis, these conditions which are essentially characterized by lifelong inflammation of the bowel do lead to an increased risk of colon cancer. Our diet, unfortunately, and Western diets certainly worse than Asian diets because we eat more saturated fats, namely red meat. So that's a big risk factor. A personal or family history of colon cancer puts us at increased risk, of course. Obesity, smoking, that sort of covers most of the known risk factors. Colorectal cancer and early detection. Well, colon cancer can be prevented through regular screening and removal of polyps, which predate 99% of colon cancers. So early diagnosis means a better chance of successful treatment, and screening should begin at 50 for all of us at, quote, average risk, but sooner if you have a family history of colon cancer, obviously if you have symptoms of colon cancer, or if you have a personal history of inflammatory bowel disease. And so recommendations for those people are usually about a decade sooner than for the average person. Screening methods for colon cancer, colonoscopy is currently the best way to prevent and detect colorectal cancer. It detects polyps, which can then be removed at the same time with a snare, and that can be done safely and easily at the time of colonoscopy. A virtual colonography is essentially a CAT scan, a special type of CAT scan And with that, you can see the polyps, but you can't remove them because your scope isn't in there. And so then you would have to have a follow-up colonoscopy to remove the polyp if a polyp was detected. Sigmoidoscopy is similar to a colonoscopy, it's just shorter. It just accesses that initial section of the colon, but it ignores the ascending, transverse, and most of the descending colon. So it would only access the sort of early part of the colon. Sometimes primary care doctors can do this in their office as an outpatient procedure, as opposed to the colonoscopy, which requires a gastroenterologist or a colorectal surgeon to do the procedure. So for most of us, if we're going through the process, we just prefer to do the full colon so that the whole area can be surveyed and polyps can be removed. Less expensive, but also less invasive is fecal occult blood testing. What you're doing there is putting a small stool sample on a cardboard card, and then you mail it into the laboratory. The laboratory puts drops of a particular solution on it, and if there's blood in the stool that you've placed on the card, then it will turn a particular color, and the presence of blood is suggestive of a polyp or some reason why there's bleeding in the intestine, and the blood is then discovered in that sort of microscopic fashion in the stool. Obviously, not all polyps bleed, or maybe they're not bleeding at the time when you collect the stool. So the sensitivity for fecal occult blood testing is much lower than the previous scopes that I've discussed, but it is also easier, less expensive, and so it's better than nothing, but certainly not nearly as good as direct visualization. Barium enemas is a radiographic test where they flush the colon with a contrast called barium, and if there's a polyp or a tumor there, it will show in the outline, and they can visualize the whole colon with that, which is good. But again, if a lesion is detected, you then have to double back and go for colonoscopy so that you can have the lesion removed. Sometimes the combination of sigmoidoscopy and barium enema are done because the sigmoidoscopy assesses that terminal portion, the sigmoid of the colon, whereas the barium enema sort of visualizes the area upstream of that. But again, a colonoscopy is one-stop shop that would access the entire colon and allow for removal of any polyps that are detected. And then finally, kind of the easiest, cheapest, and least effective is a digital rectal exam, which can detect lesions at the terminal portion of the colon in the rectum, at least as far up as one's finger goes, which is only, whatever, a couple of inches. And then you can get a stool sample and do occult blood testing on that stool sample. Again, inexpensive and a poor test, but again, better than nothing. So a little bit more facts and figures. About 150,000 cases of colorectal cancer are diagnosed in the United States each year. As I said before, it's the third most common cancer diagnosed in the United States. About 56 to 60,000 deaths per year from colon cancer, leading it, thus the second leading cause of cancer deaths in the combination of men and women. Lung cancer is number one, far and away. And then for women, it's breast, and for men, it's prostate. But if you add men and women together, since all of us have colons, colon becomes number two above breast and prostate for all comers after lung cancer. Lifetime risk for all of us for developing colon cancer is about 6%. What about staging? Basically, staging is a way of describing how advanced disease is. Stage 4 is disease that is spread to other parts of the body via the bloodstream. About 20% or so of colon cancer is stage 4 from the get-go at the time of diagnosis. Nearly half the patients who are diagnosed with earlier stage disease may relapse and develop metastatic disease over the course of their lives. Obviously, we do what we can to prevent that. The common sites of spread include distant lymph nodes, the peritoneum, which is sort of the lining of the abdominal cavity, also spread to the liver or to the lungs. This is a cartoon that describes staging. Throughout the world, we use something called the TNM staging, T for tumor, N for lymph node, and M for distant metastases. So using TNM, you can describe different scenarios, and they correlate with different stages. It's on a scale of 1 to 4, stage 1 disease versus stage 4. On the left here, you can see stage 1 disease. This is the surface of the colon with the lumen of the colon sort of darker shaded. That's where the stool would be. What you see here is a polyp growing up into the lumen of the intestine. And here the cancer cells are superficial, kind of just involving the sort of top, if you will, the mushroom cap, if you will, of this polyp. And we will refer to that as either a T1 or a T2 lesion. T1 is the submucosa. It's microscopically just below the surface, whereas T2 is a little bit deeper. There's actually a muscle layer that forms the structural integrity of the colon. And if the cancer invades the muscle layer, it's called a T2. Anyway, T1s or T2s are considered stage 1 disease. That's early stage disease. Stage 2 would be if the tumor is deeper, if it goes through the full thickness of the wall of the intestine. That would be a T3 lesion if it went through the full thickness of the wall. If it went through the wall, perforated, and attached itself to an adjacent organ, let's say your bladder or another piece of bowel or something like that, that would be considered a T4 lesion. And either T3 or T4 are considered stage 2 disease. Finally, stage 3 is if it spreads to the lymph nodes. And here you can see this in this cartoon, these little oval discs are lymph nodes in the area outside of the colon wall, in what's called the mesentery, which is the sort of support structure that holds the colon. And so blood vessels course through it, and the lymph nodes are spread throughout the mesentery. Sometimes the cancer cells spread into the lymphatic channels that you can see here and then occupy the lymph nodes. And that's a harbinger of more aggressive disease that bumps you up into the category stage 3. Finally, if the cancer spreads via the bloodstream outside the colon, it can spread to the liver, is the #1 site, because all blood leaves the colon and goes straight to the liver, delivering to the liver all the nutrients that we absorb from our food. But if there are cancer cells in there, that's also where the cancer cells end up in the liver. So if the cancer spreads, if colon cancer spreads, 9 times out of 10, it alights in the liver. And that would be a sign of distant metastases, or M1, and that's stage 4 disease. All right, so stage 1 is not too deep. Stage 2, a little deeper, but lymph nodes still negative. Stage 3, lymph nodes are positive. Stage 4, distant spread by way of the bloodstream. In terms of probability of all these things at the time of diagnosis, as I said, about 20% are stage 4 from the get-go, and another 35–40% are either stage 1, 2, and stage 3, respectively. What about genetic syndromes? These are relatively rare. It only comprises 15 to 20% of all colon cancer. Most colon cancer we call sporadic, i.e. not in the context of a genetic familial syndrome. But that being said, about 15 to 20% are. One is called familial adenomatous polyposis, that's a mouthful, FAP. That's rare, 1% or so of colon cancer is associated with FAP, and people have thousands of polyps in their colon. It's actually treated with complete colectomy prior to the development of any cancer because the likelihood of developing cancer is so high. But as I said, it's a pretty rare thing. Much more common among genetic syndromes is this thing called hereditary non-polyposis colorectal cancer, or HNPCC, otherwise known as Lynch syndrome, after the guy at St. Louis, in WashU, I think, in St. Louis, who first discovered it and described it. It can be associated with a number of different malignancies. In women, uterine cancer, endometrial is associated with Lynch syndrome, and then colon cancer in both men and women. And then some other malignancies can also be associated. There's certain brain tumors, something called glioblastoma, stomach cancer, rarely ovarian cancer. So this can be associated with a number of different malignancies, but by far the most common are colon and endometrial. Lifetime risk of developing cancer for these people is anywhere from 30 to 85%. And actually, even for these people, if they carry a diagnosis, one possible treatment for them is that they have their colon removed before they develop a malignancy. A lot of people don't want to do that. And so they'll do just frequent colonoscopies, detect and remove polyps, hopefully before they become malignant. And that's an adequate strategy. It's not as foolproof as just removing your colon, but quality of life is certainly better being able to maintain your colon. The HNPC criteria, these are so-called the Amsterdam criteria, 3210. So at least 3 members of the family with a HNPCC related cancer in 2 or more successive generations, and at least 1 patient diagnosed before the age of 50. So if that rings a bell, then you should think, maybe there's Lynch in my family, and then you can be tested for that with a simple blood test. So 3 members of the family with an HNPCC related cancer, 2 or more successive generations, and at least 1 person diagnosed before the age of 50. And obviously no familial adenomatous polyposis, which again is a super rare syndrome, but that would preclude Lynch. For those patients who have Lynch, a colonoscopy every year, 1 to 3 years, but I'd say yearly, for at least, or at least 10 years prior to the earliest colon cancer diagnosed in the family. So if dad had colon cancer at age 45, then children have to be diagnosed, screened starting at age 35, right? And then for women, an annual pelvic with a transvaginal ultrasound and endometrial aspiration starting at age 30 for early detection of uterine cancer. Remember, early detection is not the same as prevention, but certainly it's better to be detected early than not. The only way to prevent is to remove these organs with a colectomy or a hysterectomy. So what happens if you get diagnosed with colon cancer? What do you do? The answer is the diagnosis has to be confirmed on biopsy. Usually that's done at the time of colonoscopy, where the gastroenterologist will perform a biopsy and send it to pathology, and the pathology report will come back saying that there is invasive adenocarcinoma. That's what we mean when we talk about colon cancer. Then workup includes blood tests, including a blood count, a chemistry panel, and a tumor marker called CEA, carcinoembryonic antigen. CEA is a protein that many colon cancers make and secrete into the bloodstream, and you can test for it with a simple blood test. Then we do staging with scans. Usually we do a CAT scan. I just do a CAT scan of chest, abdomen, and pelvis. Some people do abdomen, pelvis, and then just do a chest X-ray. But while you're in the scanner, I just do head-to-toe CT scan. It's the most sensitive. And then appropriate referrals would be to a surgeon, a medical oncologist, and I'm a medical oncologist. Then if you have rectal cancer, which again is that terminal 12 centimeters of the colon, the radiation oncologist gets involved as well. And so we would generate a referral to them as well. So really trimodal therapy, surgery, medical, and radiation oncologists. Treatment goals really depend on the stage of your disease. For stage 1, 2, and 3 disease, certainly our goals are to cure patients, and most people are cured of their disease with the treatments that we prescribe. For stage 4, treatment is certainly life prolonging, by a significant amount, but usually not curative for those people. So for stage 4 disease, rarely, I would say 10% of the time, we can surgically remove their sites of metastases and they can be cured of their disease. But for most people, their disease, it becomes a chronic process where they're on chronic therapy to keep them alive, and people can live for several years, but not forever. Some interesting terms that you might learn are here when you go to a medical oncologist. We offer for earlier stage disease, we offer something called adjuvant therapy, meaning adjuvant is a term that means in addition to, hence the ad. And what it refers to is that surgery is the principal therapy, but we add to that by giving medications. The medications that we usually use are chemotherapy, sometimes tablets, sometimes intravenous therapy. The goals here are, again, to improve the likelihood of cure. And chemotherapy has been proven in multiple clinical trials to do that. And so in the right circumstances, we offer chemotherapy usually after surgery, occasionally before surgery. If it's somebody with rectal cancer, I won't get into that in too much detail, but for the most part, it's given after surgery. Certainly for anybody with positive lymph nodes, it's standard of care. Even if your lymph nodes are negative, if you have a T4 lesion with perforation of the colon, we would give it. And even some people with T3s, there are certain factors that would predict that we should give adjuvant chemotherapy to those people as well. This is, and again, I don't mean to get too deep into the weeds with some of the heavy medical stuff, but this was a nice, what's called a meta-analysis published 15 years ago of 7 large randomized trials looking at people who had surgery to remove their colon cancer, and then half of them had no further therapy, and half of them went on to receive chemotherapy. And these were the original studies that proved in survival advantage for giving chemotherapy in this adjuvant setting. And in these 7 clinical trials, they included people who had positive lymph nodes, stage 3, as well as negative lymph nodes, stage 2. And so I break down some of the benefit here based on whether the lymph nodes are positive or negative. If you drop down to the last bullet for stage 3 patients, i.e. positive lymph nodes, survival, or let's say relapse rates went from 48%, so nearly half the people relapsing and developing metastatic disease, to 65% not. So in other words, about a third of the people who were destined to relapse will now not relapse because of the addition of chemotherapy, and that's reflected in improvements in survival, about a 13% absolute difference in survival with the addition of 3 to 6 months of chemotherapy after the surgery. Those studies looked at a drug called 5-FU, which is really the cornerstone of the treatment that we use. Some studies that came out subsequent to that added an additional drug called oxaliplatin. It's a platinum derivative, which when added to 5-FU further improves survival by another 5 percentage points. And so for many people, the standard of care is the combination of 5-FU plus oxaliplatin. It has a nifty little name called Folfox, F-O-L-F-O-X. And that's just the first couple letters of the different drugs. It's a combination of 5-FU and oxaliplatin. For stage 3 patients, as I mentioned, pretty much everybody should get chemotherapy. For stage 2, it's more controversial, and we still hotly debate it. There is a group of guidelines that are written and published by the National Comprehensive Cancer Network, and this includes 30 major medical centers across the United States, where famous oncologists get together and review the data a couple times a year and publish recommendations for how all of us should treat our patients. And interestingly, they list as appropriate treatments for stage 2 patients everything from no further therapy, which is to say observation, to 5FU or 5FU plus oxaliplatin. So everything from nothing to everything, kitchen sink. And that just tells you that it's a nuanced and complex decision. And there's not one size fits all. For stage 3 patients, if your lymph nodes are positive, it's pretty cut and dried. Everybody gets chemotherapy. But for these stage 2 patients, it's more complicated. One investigator spent his life looking at these patients with Lynch syndrome. Ironically, he went on to die of throat cancer. But anyway, I heard him give this presentation at national conferences, and it was very compelling. Basically, he looked at the outcomes for people with Lynch syndrome, that familial cancer syndrome, the HNPCC. And again, it's about 15% of patients with colon cancer. And noted that there were differences between them and sort of garden variety colon cancer. More of them occurred on the right side of the colon, the ascending, as opposed to the transverse and the descending. There was a predominance of women, and actually they tended to be caught at earlier stage, which is interesting. Under the microscope, they looked more aggressive. They were more what we call poorly differentiated. And they have this genetic mutation called MLH1, which is the mutation that is heritable and transmitted from parent to child. And this is a survival graph looking at survival for these patients without chemotherapy, just with surgery alone. And the top graph is for people who have Lynch syndrome, and you can see there's a higher likelihood of survival as the years go on, as opposed to the non-Lynch that were the same stage. So these patients should have the same survival based on there's the stage of their disease, but in the Lynch patients, they seem to do better with a lower likelihood of relapse and longer survival by a significant margin. So for these patients, for people with Lynch syndrome and stage 2 disease, they really don't need chemotherapy, and that's pretty clear cut now. So again, that's about 15% of patients. So lymph node negative stage 2 Lynch syndrome, no chemotherapy after surgery. And that's pretty new information within the last couple of years. There was a study called the Quasar study that looked at patients with stage 2 disease and randomized them to either observation or adjuvant 5FU. And investigators, after the study was done, looked at genetic profiles of the cancer to see if there were particular genetic profiles which predicted for a higher likelihood of relapse. Again, they're all stage 2 patients. All of them have negative lymph nodes. And so the question is, was there some other way to separate them by risk? And so this is essentially a genetic footprint. And it was developed actually by a biotech company in the South Bay called Oncology. And they identified these genes as important at predicting outcome. And they were able to show that they could sort of separate people into low, intermediate, and high risk based on this genetic profile. So again, all these are stage 2 patients, so they should all have the same outcome based on stage, but no, we're going a step further and looking at genetic profile. And you can see here, low risk patients had about a 12% likelihood of relapse, intermediate had an 18, and high risk have a 22% risk of relapse. And that's described here in these 3 colored graphs. So this is the best we can do for stage 2 patients in terms of predicting the likelihood of relapse and maybe suggesting who among the stage 2 patients are more likely to benefit from chemotherapy. Obviously, if you're lower risk, the potential benefit from chemotherapy becomes quite small, whereas the higher risk, the absolute difference becomes more significant clinically, and those are patients who you might want to offer the chemotherapy to. In their study, they looked at a number of different factors that might predict, and obviously I already mentioned this thing called Lynch syndrome, which is otherwise known as DNA mismatch repair. That was very powerfully predictive of benefit. So people who have Lynch don't need chemotherapy. On the other hand, people whose tumors are deeper, who perforate the colon, the T4s, do worse. And this confirmed that. No surprise there, but it's always nice when common sense is borne out by the statistics. Tumor grade, how aggressive do the cancer cells look under the microscope? High grade does worse than low grade. Again, makes sense. Sometimes the surgeon doesn't take an adequate lymph node dissection. And if you have an inadequate lymph node dissection, that bodes poorly because maybe there are positive lymph nodes hiding that the surgeon didn't take. So it's really important that the surgeon take at least 12 lymph nodes to make sure that they get an adequate sampling. So they found that people who had a insufficient lymph node sampling did worse. Invasion into those lymphatic channels, so-called lymphovascular invasion, again, portends a worse prognosis. And this recurrence score that I just described, based on this genetic profile, also is highly predictive of risk of recurrence. So these are the things that we might look at in a stage 2 patient to help them make a decision, an informed decision about whether they should or should not have chemotherapy, right? So if they have Lynch syndrome, the answer is no, they don't need chemotherapy. If they have a T4 tumor perforated through, yes, they need it. If they have high-grade disease versus low-grade disease, yeah, maybe they would need it. If they had an inadequate lymph node sampling, we don't see that anymore because the surgeons know that now, and they make damn sure that they take at least 12 lymph nodes. So that's rare, but sometimes we see it from referring communities where the surgeons are less well versed. And the presence of lymphatic invasion, again, might portend a worse prognosis and signal the need for chemotherapy. Or this recurrence score. If you had somebody with a high score of 22 versus a low score of 12, that's somebody who I might recommend chemotherapy to. All right, so it's a complicated conversation, and it really gets deep into the weeds of the specifics of the patient. All of these people have the same stage 2 disease, but there are many other ways that you can parse it to help differentiate risk. What about after the fact? Well, let's say you finish your chemotherapy, what do we do for you then? And you go into what's called surveillance. And this is all driven by data as best we can. We see our patients every 3 to 4 months. We do lab work, including this marker called CEA. We do CAT scans yearly for 5 years, or obviously if somebody had new symptoms, or a rising CEA as a marker for recurrence of disease that would prompt a CT scan. Colonoscopy is done at your 1-year anniversary, and then as long as it's negative, 3 years after that. New on the stage, really in the last year or 18 months, is something called circulating tumor cell DNA, or CTC DNA. Essentially, this is the proverbial needle in a haystack. By a simple blood test, they're able to detect DNA from circulating cancer cells for people who are at who harbor microscopic recurrent disease. So before your CAT scan is positive, maybe even before your CEA is elevated, these specialty labs can detect abnormal DNA from cancer cells shed into the bloodstream. There are a couple different companies that provide this test now. And so for my high-risk patients, I'm doing this on a routine basis every 3 to 4 months. Moving into sort of the last part of my talk is talking about different drugs. And again, some of this may just seem like alphabet soup to a lot of people, but for those of us who work with it 18 hours a day, it's what we do. It's our passion. So I already mentioned 5-FU is the cornerstone for colon cancer. Been around since the early 1960s. There's a B vitamin, vitamin B6 called leucovorin, which interestingly, totally randomly increases concentrations of 5-FU chemotherapy in cancer cells, but not in non-cancerous cells. So it sort of boosts the efficacy of 5-FU it has no anti-cancer activity on its own. It only works in conjunction with 5-FU, and that's the only chemotherapy that it does this for. But anyway, we give the vitamin B6 along with the 5-FU so as to augment its efficacy. Then a couple other chemotherapy drugs came on the scene, something called irinotecan, and then oxaliplatin, which I've already mentioned. 5-FU historically is an intravenous drug, but it's also available now as an oral medication called capecitabine. So 5-FU and capecitabine are essentially the same thing. One is just intravenous and one is oral. So those three chemotherapy drugs are essentially what we got. There isn't a long list. It's really just three chemotherapy drugs, 5-FU, irinotecan, and oxaliplatin. We combine 5-FU with either of the others or sometimes both. And they sort of squish the first couple letters together to make the name of the cocktail. So there may be patients online, I'm not sure, who might be familiar with this, but if you get, for example, 5-FU plus oxaliplatin, it's called Folfox. If you get 5-FU plus irinotecan, it's called Folfiri. And if you get all three together, it's called Folfirinox. And again, it's just the first three letters of the different drugs kind of smushed together. And then in the last little bit, we've had the introduction of a new type of medication, not chemotherapy, but rather biologic medication, targeted medications that hit particular pathways that are active in these cancers. And I'll describe those two. One of them is called bevacizumab or Avastin. And I was involved in the original trial that confirmed benefit to Avastin and got it FDA approved in 2004. And then another drug called cetuximab, which also is a dynamite drug. Both of these are antibodies made by a mouse, but the antibodies happen to target a specific pathway that's active in the cancers, and by targeting those pathways, decreases cell growth and improves cancer survival. They're usually given in combination with the chemotherapy, occasionally can be used on their own, but really are best when given in combination with chemotherapy. So let's talk about how they work. These are two different active pathways that are relevant in a number of different cancers. One is called the epidermal growth factor receptor. That's the EGFR pathway, and cetuximab hits that one. And then the other one is called the vascular endothelial growth factor, or VEGF, and the Avastin hits that one. And this is a cartoon that sort of describes a cancer cell, and when EGFR, which is a receptor, think of it as a lock and key, where the lock is present on the outside of the cancer cell, and when a certain protein binds to it, think of it as the key fitting into the lock, it causes downstream growth of that cancer cell. So what we want to do is we want to inhibit the interaction of this protein in purple with the receptor, which looks like sort of two smokestacks standing up. We want to block this interaction, and by doing so, it would block the growth and spread of this cancer. It turns out that EGFR is overexpressed in a number of different cancers: colon cancer, throat cancer, pancreatic cancer, lung cancer, to name a few. And so an anti-EGFR strategy is appropriate in many of these different cancers. And so tonight I'm just talking about colon, but you'll see this type of drug used in a number of different cancers. And basically, this was the initial study that showed that cetuximab improves survival over supportive care alone in people who had exhausted their other options. And so now, once we know that's true, we start to add it to chemotherapy and use it earlier on in the evolution of the disease. It turns out it'd be nice to know if we could test for the presence of this EGFR receptor on the cell surface, but the tests that we do aren't very good at predicting who has it and who doesn't. The technology just hasn't come along. But there's another gene in the pathway called KRAS. Actually, let me go back to this. uh, 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 let's see, I thought it would show it, it doesn't. But basically, think of KRAS as a intermediary in the pathway of EGFR. And it turns out that people who have KRAS mutations don't respond to treatment. 1% of them responded, which is to say nobody. Whereas people who didn't have the KRAS mutation were much more likely to respond. And so what we do now, before we offer somebody an anti-EGFR drug like cetuximab, is we test their cancer to make sure that they don't have KRAS, because people with KRAS don't respond. So you have to be KRAS normal, or what we call KRAS wild type. So if you're asking your doctor about Erbitux, cetuximab, you would need to look at the pathology report, make sure that the doctor tested it for the presence or absence of a KRAS mutation. And if there's a mutation present, and about 45% of people do have a KRAS mutation present, they do not respond to cetuximab, so we don't waste our time with that drug. So the other 55% who don't have a mutation, those are the people who we would offer that medication to. Next on the hit parade is the VEGF, or vascular endothelial pathway. And this is really a brilliant bunch of work that was first described by a pediatric surgeon at Harvard by the name of Judah Folkman. And he noticed in his patients with cancer that when he did surgery on them, the tumors were tiny, the size of a pinhead, 1 to 2 millimeters, until they developed blood vessels that fed them. And he postulated, he sort of recognized it, that these tiny tumors that were like salt and pepper everywhere, or little kernels of rice, if you will, did not have any blood vessels. Whereas a larger tumor was filled with blood vessels, feeding it oxygen and other nutrients. So he said, well, there must be something that happens between the tiny tumor and the large tumor that drives new blood vessels to feed the tumor. And he said, well, we're going to call that the angiogenic switch. In other words, something happens where the tiny tumor signals to the body, feed me, let me breathe. And the body unfortunately obliges and grows new blood vessels into the tumor that allow it to grow and, of course, spread. That's a bad thing. He dedicated his life then to figuring out how this happens. He and others who worked with him and in other labs discovered that there's a protein that the cancer secretes into the general area around the tumor. And they named that protein vascular endothelial growth factor, or VEGF. And VEGF is sort of the kingpin in the growth of new blood vessels. And this is true in the normal state, meaning if you cut yourself and your skin is trying to heal and needs to grow new blood vessels to facilitate the healing, your body will normally secrete VEGF into that area that will prompt the growth of new blood vessels. But it's also true in the cancer realm that the cancer will unfortunately secrete this stuff too, this VEGF, and your body doesn't know any better and responds by growing new blood vessels into it. So we work to block this. So bevacizumab, or Avastin is the brand name, is an antibody that was developed specifically against VEGF. And like I said, it's made by a mouse. So it's a mouse antibody against human VEGF. And when it binds to the VEGF, it prevents the blood vessels from growing, which is terrific. So this is a study that I was involved in that tested this hypothesis. And in this study, patients had metastatic colon cancer. Everybody got the same chemotherapy. Half of them also got Avastin. And what do you know? That group lived significantly longer, and the drug was FDA approved and is now a cornerstone for treatment of metastatic disease. Safe, a little bit of high blood pressure you get from Avastin, so people have to watch their blood pressure, and we monitor them for protein in their urine, and rarely you get people with significant protein in their urine. In that case, sometimes we have to hold the drug until that recovers. So where are we now? Well, we have some challenges and we have some current advances, which are pretty exciting. But I think it's much more beneficial to prevent a cancer than to treat it once it's set up. And so I would say we do only a fair job at screening. And one of the important things about Community Health Resource Center is that we do our best to try to serve our community by offering screening programs. There are a lot of cultural divides where different communities, sub-communities within our city are more or less apt to seek out screening. So access to medical care, the interest in the medical care varies. So I think there's sort of an educational need to make sure that patients know that this is a safe and important thing to do. And so getting your colonoscopy at age 50 for the average risk patient without symptoms is super important. I'll say my younger brother, who's in his early 50s and a very bright man, an attorney and a high-powered guy, but refused. I told him, "Have you gotten your colonoscopy?" And he said, "Well, I don't have any blood in my stool." I said, "Oh my God, I can't believe it. You don't need blood in your stool for it to be appropriate. In fact, if you have blood in your stool, you've probably waited too long." Right? So screening implies lack of symptoms. So screening means you have no symptoms, but you still are at risk for having a polyp. You go in there, find the polyp, snatch it out before it has a chance to evolve into cancer. And so that's super important. So by all means, tell your friends, tell your loved ones, tell everybody to seek appropriate screening for colon cancer. What's next? Selecting which patients with stage 2 disease should get adjuvant chemotherapy. I talked about a number of different factors, the genetic profiling, the circulating tumor cell DNA is another important step in that evolution, but I think it's a constant evolution. We haven't arrived at the perfect way to predict who will benefit and who won't. And so I think it's still a conundrum who should get adjuvant chemotherapy for stage 2 disease. Further improvements for treatment of metastatic disease. I talked about 3 chemotherapy drugs and 2 biologics, so 5 drugs total, and new drugs are coming all the time. They tend to be in select populations based on specific genetic mutations in the disease. There's something called HER2/neu, which is famous from the breast cancer world. About 20% of breast cancer has this thing called HER2/neu. It turns out that about 5% of people with colon cancer also have HER2/neu. And now the same drugs that we've been using in breast cancer for decades, we can now use in our patients with colon cancer. Similarly, another mutation called BRAF, famous from people with melanoma, but it turns out about 5% of people with colon cancer also have BRAF. And so those same drugs that we've been using in melanoma BRAF, we can now apply in colon cancer BRAF as well. So it's appropriate for, if you have metastatic disease, to be screened for these markers. Do you have HER2? Do you have BRAF? So because there are new drugs that have been approved within the last few months that are appropriate for those somewhat unusual patient population, but still for those who have it, this is a very important fact and an actionable mutation. Immunotherapy, everybody wants to tag along the immunotherapy front. You hear about immunotherapy for lots of diseases, lung cancer, for sure, it's commonly used, melanoma again. What about colon cancer? It turns out if you have Lynch syndrome, again, that's that 15% of people who have the familial syndrome called Lynch, they tend to respond really well to immunotherapy, like 70, 80% of them respond really well to immunotherapy, which is amazing. But if you don't have Lynch, if you have sort of garden variety, what we call sporadic colon cancer, that's 85% of us, immunotherapy doesn't work, not at all. And so that's a disappointment. And I think we're trying to actively research how can we tinker with immunotherapy to make those non-Lynch patients potentially respond as well. And so here at CPMC, we're actively involved in some of those clinical trials. More recently, like in the last couple months, we've found that people with metastatic disease that originated from the right side of their colon may behave differently than people who had it on the left side of their colon, vis-a-vis these EGF and VEGF strategies that I described before. It used to be, it was sort of dealer's choice who got which agent. Now it seems clear that people with right-sided disease should get one and left-sided disease should get the other. So kind of, interesting facts that again have been a recent evolution in the last couple months. So with that, I think I've given you a textbook full of ideas and thoughts on colon cancer. Happy to open it up to questions now, and appreciate your time.
Thank you, Dr. Barron. I hope that everybody can see my screen, or not my screen, my camera. We have a few questions here that were asked live in the Q&A. Most of them are talking about the screening methods, such as colonoscopies. Could you speak to a recent study that showed colonoscopies made no difference in death rates?
No, there've been multiple studies that show that it has. So I don't know that one in particular, but so I can't really speak to it. But certainly, yeah, I don't know. Can't really address that. Colonoscopies are not so common in some Western countries, Ireland, England. How do they compare with the U.S. in terms of death from colon cancer? Yeah, so that's a lot of that is access to care. Colonoscopies are expensive. And so, in the UK, I actually worked in London at Hammersmith Hospital for a while. So I have some familiarity with NHS, National Health Service. And, you wait 1.5 years to get on dialysis. And, you can't get an MRI for your knee and lots of things. So there is sort of de facto rationing for a lot of care. So colonoscopies are more expensive. So in places that have that invest less of their GDP in healthcare, you do less expensive things. So you can do a flexible sigmoidoscopy in a primary care's office, and that captures a significant portion of polyps. Can be done less expensively because it's an office procedure. It's not done by a subspecialist. It's done by your internist. You don't need sedation for it. So I think that's one option. Or, of course, fecal occult blood testing is cheapest of all. And Kaiser proved that 15 years ago that fecal occult blood testing can prolong survival based on early detection of bleeding polyps and early cancers. So, I think colonoscopies are, I would say, the gold standard. Because they have a higher sensitivity and they can be therapeutic as well as a means of detection. But there aren't enough gastroenterologists to screen everybody, probably. And maybe there are resource limitations. And so using some of those other modalities may make sense in certain populations. I think it's advisable to have your you think it's advisable to have your genetic profile done by 23andMe? I'm not a big fan of that. It's fine if you do, but you need to know what it means. I think there was a court case against them that said that I'm pretty sure that for positive findings, there has to be genetic counseling. And that's just important. You can't just get a test in a vacuum and not have adequate education about what it means and how to manage it. And so that's my main concern about 23andMe and others like it. I think it's for the general population, it probably doesn't make a lot of sense. Certainly for people who are at higher risk based on their family history for having genetic syndromes, then it makes all the sense in the world. But we have more sophisticated genetic testing, either through Ambry or Myriad, that are two companies that have commercial tests available.
We have some, and this is a good time for me to let everybody know that this class was marketed for 1.5 hours. Our time constraints are actually for 1 hour today. And Dr. Barron, is there room for a couple of more questions?
Sure.
All right. If there is colon cancer that runs in the family, at what age should parents consider recommending getting screened for their children?
Yeah, it's sort of hard to give a one blanket answer for everything. In general, you wouldn't be wrong to say 10 years before the youngest person was diagnosed with colon cancer. So if grandma had it at 55, then you getting it, child getting it at 45 would be fine. I'd say that's 10 years before the age of diagnosis of the youngest person with that cancer in the family.
And I know that there is somebody who's raised their hand in the crowd. Darlene, would you still have your question? Let us unmute you on our end. Oh, it looks like my computer is frozen, so I'll go to the next question here.
Sure.
Can you discuss the role of germline and somatic results in your treatment of colon treatments or colon cancer?
Sorry, I was coughing when you, for an important word, the role of what?
The role of germline and somatic results in your treatment of colon cancer?
Yeah, so those words, germline and somatic, refer to the type of genetic mutation that you are assessing. So if you're looking at genetic mutations in the cancer, you're talking about somatic mutations in that cell, the soma. If, on the other hand, you're talking about genetic mutations that you might have inherited from mom and dad and could potentially pass on to your children, those are in every cell in your body, including your sperm or egg, which is how you confer it to your progeny. And those are called germline mutations. So every cancer has somatic mutations. It wouldn't be cancer if it didn't have mutations. So we do genetic testing on everybody with metastatic disease and many people with earlier stage disease if we believe it will contribute to their care. For germline, which is usually a blood test, but sometimes from the inside of your cheek, but now we do it as blood, that is germline. And there you're looking for the Lynch mutations, or in breast and ovarian cancer, you would be looking for something called BRCA1 or BRCA2. There's lots of different genetic syndromes where you test for germline mutations.
Thank you.
Yeah.
We have one more question here, I promise.
Yeah.
Is there a connection between IBS and colon cancer?
Let's see. Inflammatory bowel disease, yes. Crohn's and colitis, not irritable bowel syndrome. So probably not with irritable bowel syndrome, which is a sort of a lesser intensity kind of phenomenon. So, bloating, constipation, irritable bowel syndrome, probably doesn't increase your risk of colon cancer.
Thank you for that. I believe that every other question has been addressed in your presentation. I'd love to thank you for your time and thank you for sharing just a little bit of your passion for everything that you do at work.
Sure,
and we are really grateful for having to host you.
Well, thank you very much. I appreciate the opportunity. And thank you, everybody, for your interest and your participation.